Okay, welcome everyone. This is the webinar on Introduction to Economics and Health Economics. It's run by the MIDAS team in the ARC Northwest Coast. I'm Valerio Benedetto. I'm part of the MIDAS team, which some or many of you will know is the methodological theme in the ARC Northwest Coast. And I'm also a research fellow at UCLan. I'm co-running this webinar today with Luis Felipe, and I'll let Luis introduce himself as well.
So hello, my name is Luis Felipe, and I'm a lecturer at Lancaster University, but I was also a member of the ARC, the MIDAS team in the ARC, very recently.
So yeah, thank you, Luis is an honorary member of MIDAS.
Exactly.
Yeah. And he's, of course, helping us with the health economic activities across the MIDAS. So today's webinar, as the name suggests, is all about economics and health economics. We're not trying to explain everything about economics and health economics, but hopefully we will explain the key things to remember, the key things to understand about economics and health economics. We try to prepare the presentation today for people who don't have any knowledge at all about economics and health economics. So for some of you, there might be concepts which are you're familiar with. Well, this is probably a nice opportunity to refresh this concept, to have a general recap around economic and health economic concepts. What I'm going to say is that the slides will be made available after the session, so that's something we are happy to do and to circulate. We will also send the link to the recording after the session, and everything from today will be available to you. Before I start, I also like to introduce very quickly Andy Clegg, which is the MIDAS theme lead. Many of you will have seen Andy, and is part, of course, of our, let's say, health economics team within the MIDAS team. So, hi, Andy. Any difficult questions today, I think we'll direct them to Andy at some point. And we also have a new health economist in the MIDAS theme, which is Misael. Misael joined the MIDAS at the beginning of March, if I'm correct. And we are very happy to have him with us, and he'll help us today with monitoring the chat, so the questions you might have around what we cover during the webinar. Now, let's make a start. So this is the overview what we will cover today. Of course, one of the main focus today is about talking about economics and health economics. That's the part that Luis will cover in first, and it's about defining what economics is, what health economics is, but also try to consider why economics and health economics are important. And Luis will cover different key concepts in economics and health economics, things like scarcity, for example. I'm not going to reveal too much now, but Luis will provide you with a definition and examples around different concepts to make things a bit clearer in terms of understanding economics and health economics. That's the first part of today's session, and then we will take probably a break if you have time, probably a 10 minutes break, and then we will resume, and I will talk about health economic evaluations more specifically. Again, I'm not going to try to cover everything, just to give you a bit of flavor around what is an economic evaluation, the common types of economic evaluations, and the main findings from an economic evaluation. And then at the end, last but not least, we got the presentation of the RACE scores. RACE is the rapid conversion of economic evaluations. As the name suggests, is going to be part of the RACE program, which I assume many of you will have heard of. And it's a new initiative we are launching from the MIDAS team, and I will talk about this initiative a bit more towards the end. At any point, if you have any questions, feel free to either raise your hand or write in the chat. We'll try to monitor the chat as much as we can and try to answer any queries you might have. But now, without further ado, I'll leave the stage to Luis. Thank you, Luis.
Okay, thank you, Valerio. Let me say that at least in my part, feel also free to just unmute yourself, and if you have anything to say, just say it. Any question, feel free. Don't worry. So let's start. What is health economics? Well, sorry, what is economics? Well, you would be surprised. I don't know what you think it is. Most of you probably know a little bit. Some of you probably know exactly what it is, but at least you would be surprised if you saw what some people think economics is. For instance, I still think my parents think that I'm good at finance or accounting, which is not true. In fact, and Valerio can confirm, we do have at least one course of each during our undergraduate, but no, we are not experts in finance or accounting. We just understand some very basic concepts. So no, don't ask me where you should invest your money. I don't know. I also have a friend, and I think there's no, like I can explain it to him the amount of times I want. It is never going to change. He's always coming to me. Oh, where should I put my money? Oh, let's put our money together and try to invest and create a business. Again. While I think economics helps you understand, for instance, a little bit, just a little tiny bit of how to manage a business or something, it's really not something you learn in economics. It's probably more towards management or something. So what is it then? If you want, feel free to unmute yourself and give it your try to what is the definition of economics or what do you think it is. I'm glad to hear you. If not, I'll just continue. So economics comes from the Greek word oikonomia, which means household management. So in here, in fact, it could seem a little bit more like management, but in its evolution, it went a little bit further away from this simpler concept, let's say. So let's try to investigate what economics is. Let's go to Google. Let's write definition of economics and let's see what we can find. So the first we find in Google is the dictionary definition of economics, which says it is the branch of knowledge concerned with the production, consumption, and transfer of wealth. Well, while this is not incorrect, I believe this is not complete. So it is the main concepts for me at least are not here. So let's try another one in Google. I don't remember where this one is from, but it says that economics is a social science, so very interesting, that focuses on the production, distribution, and consumption of goods and services, and analyzes the choices that individuals, businesses, governments, and nations make to allocate resources. So very interesting. First, it says social science. Again, at least I'm not sure if all economists, but at least if you want to annoy me, is to say that economics is an exact science, which I think most people think economics is an exact science, and it cannot be further away from the truth. Economics is a social science, and if I wanted to really put my shirt on and say that economics is the best, I could almost say that economics is almost the mother of social sciences, and let's see why. You can see that in there it says also that analyzes the choices that individuals, businesses, and governments make. Choices. So this is very interesting because it is what I will tell you that economics is. And then, of course, to allocate resources. I quite honestly, this definition is very, very, very good. But let's see what else we can find. Okay, let's go to Wikipedia, and we can see again that it is a social science that studies the production, distribution, and consumption of goods and services. So economics focuses on the behavior and interactions of economic agents and how economies work. So similar to the previous one, not as complete, in my opinion. It doesn't say exactly the choices, which is the part that I like the most in the previous one, but it's good nonetheless. So yeah, let's keep the one in the middle. So economics is about choice. So if you want to have a smaller, simpler definition of economics, that when you are asked what economics is, you can just say, keep this one, which is economics is the science that studies choices. And that's it. Don't believe it, but it is. It is the science that studies choices. And this, in fact, is enough to describe economics. So you'll see that every time in your life, for instance, you go to a supermarket, you have a certain amount of money, and you need to make choices, and you decide to buy some goods, you don't buy some others, and so those choices need to have a reason, and that's precisely what economics does, is try to understand why are you buying some things and why are you not buying some other things. For instance, in health economics or in the realm of health, you can, for instance, try to understand why the decision makers, let's say, are, for instance, buying some drugs or therapies or some more general treatments and not others. So this is going to be fundamental. So that's it. Economics wants to know why these choices have to be made. One of the reasons why you are interested in trying to understand choices and trying to understand how choices can be made more efficiently, how to optimize decisions, it's because resources are limited. And basically, if resources are limited, we cannot have everything we want. We need to understand what are the ways we can have to make the best use of those resources, which means basically how can we make the best choices. So again, last part, economics is the study, summarizing what I've been saying, economics is a study of choice between alternative uses of the scarce resources available in the health sector. So this is health economics, sorry. So yeah, defining health economics. So this is already the definition. It is basically applying what we have for economics, but in health economics. So it's the field of economics that studies the allocation of resources to and within the healthcare sector. So it's basically the same. Economics studies choices, health economics studies choices in the healthcare sector. It is a relatively new subdiscipline of economics. It's really new. Most people will tell you that it was born in 1963 with this paper for Kenneth Arrow, a famous Nobel Prize winner, this economist. And it was a paper published in the American Economic Review, which is basically, if not the best, at least top 3 of the best journals you can land on in terms of economics. And yeah, this paper is considered probably the first kind of paper in health economics. And it is a very interesting paper. Basically, what Harrow finds or what Harrow comments is first economics, first health has a market. There is a market for health. Well, not directly for health. We say this is just a detail, but we say that it is a market for healthcare, and then through healthcare we can achieve health. But yeah, the first thing that Arrow notes is that it is a market. So don't be scared. This is a traditional supply and demand graph, a very simplistic supply and demand graph that is very common in economics in general. So usually what you have in these types of graphs is that in the y-axis or the vertical axis, you have the price of some good. For now, forget what is written in there. And on the horizontal axis, which usually is the x-axis, you have the quantities of that good. So generally speaking, you probably came across the law of demand, where you have that when the price goes up, the quantity that you demand for some type of good goes down. And even if you didn't, this is probably very intuitive. Because if you go to a supermarket and you find out that some goods that you want to buy are cheaper, sometimes you say, okay, I'm just going to buy more of them. If they are more expensive, you probably are going to buy less of them or not buy anything at all. So you can see clearly in your experiences, in your daily lives, that in fact, when the price is higher, you buy less. When the price is lower, you buy more. So you have this relationship, this decreasing, this downward sloping demand, decreasing demand. Now, the other one is a little bit trickier, but still intuitively it shouldn't be that hard, which is you usually have a supply which has the opposite direction. So the higher the price, the more the supplier is willing to sell. The lower the price, the less the supplier is willing to sell. So this is the typical demand and supply interaction, right? So it should be, it's more or less intuitive, right? I'm not going to explain the supply in detail because it's a little bit harder, but yeah, if you are selling something and if people are giving you more for it, are willing to pay more for it, you understand that the supply should be increasing, okay? For now, let's stay with this. And when supply meets demand, you have an equilibrium, which in this case would be in this P star, Q star, so this price and this quantity. Now, one of the things that Kenneth Arrow realizes is that there is in fact a market for healthcare in particular. So if you put here price of healthcare and if you put here quantity of healthcare, it still applies. The rules of the market still applies in terms of you have a demand and you have a supply. Think about yourself. Of course, you may say that in terms of demand, if you are really sick and you really need to get treatment, you probably will pay everything that is necessary to get treatment. But that just makes the elasticity, and sorry about the terminology, the elasticity of demand a little bit lower, which means basically that you are less sensible to price in the case of health. But it should still be the same. If the price is higher, you would require less healthcare. If the price is lower, you would probably be willing to buy more healthcare. Think that you need to do, for instance, a surgery, and you go to the hospital, but you have several options. You have the option of just doing the surgery, stay there the least amount of time possible and go home, or you can stay there a little bit longer, have another type of treatment, have some more time to do some tests and some things after the surgery and so on. And probably you may choose the second one if it's cheap enough, but if it is more expensive, you probably want to get the simpler treatment. So there should be, in fact, downward sloping demand in healthcare. Now, supply, the same. Of course, this is going to become tricky because most of the times, for instance, here in the UK, you have the NHS providing it. So you don't really have this interaction between price and quantity, or at least not directly. But imagine that we are talking about a private hospital. It should still be the same. If the price is higher for a certain service, you would be willing to offer more than if the price is lower. Okay, so yeah, for now, let's say that it follows the principles of traditional markets. Now, the interesting thing about what Kenneth Arrow talks in that paper is that it is really not exactly like traditional markets. While there is a traditional supply and demand interaction, there's a lot of other things that are not going to be as in other markets. And those things are basically what we call in economics market failures. And to explain you this very, very briefly, you probably heard about Adam Smith and the invisible hand, right? The idea that the markets will find an equilibrium by itself. Now, there's a lot of criticism towards this, and it's not because it is wrong. In fact, most of the markets, most, I probably shouldn't say most, but a lot of the markets can find equilibrium from themselves. But this is only true. This invisible hand by Adam Smith only works if you don't have any market failures. If you do have market failures, it doesn't work. And guess what? In healthcare markets, you basically have a lot of market failures. And I'll give you some examples. For instance, uncertainty. There's a lot of uncertainty in the healthcare market. You never know when you are going to get sick, for example. So your demand for healthcare is quite uncertain in itself. Also, if you get sick and you go to the hospital, and you go to your doctor and your doctor prescribes you some treatment, you are not sure the treatment is going to work. So this is already something that you don't find in other markets. You go to the supermarket, you buy some ice cream, you get some ice cream. That's it. Here, you never know when you are going to want ice cream, let's say, because you never know when you are going to want some treatment, because you don't know when you are going to get sick. And then when you buy the treatment, you don't know if it is going to work and if it is going to give you more health. Then you have, for instance, asymmetric information, which there's two types. There's the asymmetric information in the sense that, for instance, the patient knows better what the patient is feeling than the physician, for instance. But importantly, the physician knows a lot more what to do with any information the patient gives him, gives her, rather than the patient. So if you go to the hospital, you say, okay, I have a stomach ache, I have this, I have that. And the physician is the one that knows what you may have in terms of a potential disease or some health problem. This can create complications, and without going too much in detail, one of the complications can be supplier-induced demand, where, for instance, the physician can make you do a little bit more than you should have to potentially make more money, for example. Can also create complications with insurance companies, because if you are the patient and you don't know more about yourself than the insurance company, it may be hard to find the equilibrium premium that you should pay for an insurance, for example. So yeah, it's tricky. Now, there's barriers to entry. If you, I don't know, you and your friends decide to open a pub, you put some money together, you buy a place and you open a pub. If you decide to open an hospital, you can't, I guess. So it's probably not easy. So there's a lot of regulation. It's not like I want to open an hospital and you open it. It's quite tricky. This is very important because in traditional markets, it's easy to enter, it is easy to leave. So this is also going to help the equilibrium being found by itself, but not in regulated markets like healthcare. Now, there's a lot of externalities, and this is a very important concept in economics in general. And this is the idea that markets can affect other markets or be affected by other markets. In the case of the healthcare market, it should be quite intuitive because, for instance, if let's say you are healthier because the healthcare market is working very well, people are healthier in general. It means, for instance, that they will be better fit for work, so the labor market should be positively affected by the good outcomes in the healthcare market. Conversely, you can also say that if something is not working correctly in the labor market, let's say that people are working too much, people do not have the conditions they should have in their labor market, in their jobs, they can start develop, for instance, mental ill health, which may which may affect the healthcare market, where more people will need healthcare services, particularly in this example around mental health. So this is also, again, something very important because when in the presence of externalities, the markets will not be able to find the correct equilibrium. They will find some equilibrium, but it's not the correct one. It's not the one that the society desires. Finally, the last example that I have for you, the presence of third-party agents. When you go to a supermarket, again, you go there, You buy your ice cream, the supermarket is selling you your ice cream, you pay, you get the ice cream, you go home. In the healthcare market, it's not exactly like that. You go to the hospital, let's say, you meet with a physician, okay, you pay. If it is a private hospital, for instance, you pay, you get the treatment. But for instance, usually, well, in this example, it was not probably the best, but usually there's an insurance company, like in the case of the US, where you have mostly private hospitals, but then there's also the insurance company. In here, in the UK, for instance, you go to the hospital, NHS, so you have you, the consumer, the hospital, the provider, but then you have the state serving as a third-party agent. So it's really not typical to have these in other markets. So again, this makes the healthcare market, let's say, special and harder to work with and analyze. Now, let's go back then to economics in general, and let's talk about key concepts in economics. And let's talk about scarcity, which is what we were talking about already before we went to the health economics. All the problems in health economics are going to derive from this scarcity problem. Let me just tell you that this is a little bit incorrect. So we have that the problem is that demand is higher than supply equal to scarcity. Technically, this is incorrect. It shouldn't be demand, it's need. It shouldn't be supply. It should be, resources. So need is always higher than resources, which leads us to scarcity. And again, scarcity implies making choices. So how to allocate resources. And this is going to lead us to what I call the god of concepts in health economics, which is the opportunity cost. So let's summarize this. Resources are limited. There's no infinite resources in the world, so you never have infinite money. You never have, importantly, infinite time. So you can never buy everything you want. You can never have time to do everything you want, which means that choices need to be made. Choices need to be made, but then if you need to make choices, you need to choose how to allocate your resources, okay? And every time you make a choice, every time you decide on how to allocate your resources, there's always something that you are giving up. Let's say you have a certain amount of money and you go to the supermarket and you decide to buy ice cream with that amount of money. Probably you are not buying chocolate. So you are giving up chocolate in order to buy ice cream, okay? So this leads us to this very important concept, which is the opportunity cost. And the opportunity cost, it is basically what are you giving up in order to make a choice. When you want something and you get something, what are you not getting? And if we need to define this opportunity cost, it is this one here. It is the value of the next highest valued alternative use of that resource. Okay. You go to a supermarket. It's a little bit tricky, but you go to a supermarket. You decide that what you really want at that time is to buy ice cream. What would be your second option if you had not bought the ice cream? Let's say it was chocolate, buying chocolate. Then your opportunity cost when you buy ice cream is the chocolate you didn't buy. Okay? And you will see that opportunity cost is a very, very important concept, and it's going to be everywhere in economics, but in particular in health economics, because, for instance, when you decide in the healthcare sector to buy a certain treatment, let's say the decision makers decide to buy a certain new drug or a certain new treatment, they basically need to understand with that money, what could they have if they did not buy that treatment or drug? Would it be better or worse? Because if the opportunity cost is higher than the benefit you are getting from your choice, then you did some mistake. Now, I've been talking for a long time, so now let's do one exercise to see if you understood what opportunity cost is. If you didn't, don't worry, but risk it. Say something, please. I will need you now. So imagine, in this example, imagine you need hospital treatment and you have two options. First option, you can go and pay for a private hospital and get treated immediately. So next day you get treated, that's it. Now, second option, you decide to go with the NHS, but you need to wait, and you need to wait several months, and then you get treated, and you get treated for free. You don't pay anything. Now, first question, what is the opportunity cost of choosing option one? And please now, I would really like to have your participation. So I'll give you some seconds, but please join and tell us what you think either in the chat or in just unmute yourself and say.
One of the participants said that the amount of you will need to pay the private hospital is opportunity cost.
Close, very close. Yes, it has to do with when you pay, you need to pay for the private hospital, so it is correct. But the money itself is worth, how can I say? The money itself, it's not the opportunity cost, is what you could be doing with the money. So what other answers do we have?
The amount of money spent, the money on the money, one. Not having the money for another use versus relief from symptoms.
Mm-hmm. Do you have more?
The chances of feeling better sooner. The opportunity cost will be your recovery from illness, shorter period.
Mm-hmm.
That's it.
Yeah, so I think we have the answers in there basically. So yes, I think those two are the ones that make sense. So yeah, when you pay for a private hospital, it's true you lose the money. So what could you be doing with the money? Of course, in here we are not giving you the second best alternative for that money. So yeah, you cannot give a precise answer. So the correct answer would be that the alternative use of that money. Let's say, for example, that we were planning to go on a trip on vacation to Italy, and because we are paying for this treatment in a private hospital, we don't have the money anymore to go to that vacation in Italy. So let's say in this case that the opportunity cost is not going to Italy on vacation. So just to give an example, but the general answer is what else could you be doing with that money? What would be the best option? That would be the opportunity cost. Now, someone said that getting treated immediately is the opportunity cost. Not quite. That is going probably to be in the second one. So let's go to the second one. Waiting several months and getting treated for free in the NHS. I think this one is trickier. What is the opportunity cost of choosing option two in this case? And feel free again to write in the chat. I will give you a few seconds, and then if Misael can help me, that would be great.
The cost to you of living longer with the condition. Someone can go on holiday, the healthier time spent doing something else instead of waiting when sick.
Mm-hmm.
The time that could be used to do other important things if you were not ill or have recovered.
Mm-hmm. Yes, again, you have another one?
Okay, yes, having the condition for longer versus getting better now.
Yes, in this case, people are not paying nothing in terms of money, but I think most of the answers realize that people are paying something in terms of time, or at time free of illness. So that time free of illness is going to be the opportunity cost. Of course, if we want to be a little bit more specific, again, we would need to give examples, but let's say that because the person is ill, that person cannot, let's say, cannot go on vacations and enjoy the vacations as she would like to, because that person is ill, or cannot do sports and cannot derive pleasure. In economics, we call it utility, but cannot derive pleasure and welfare from doing the things that person likes. Or if we want to go a little bit more in deep, it can even be that because that person is sick, that person cannot work and is getting less money monthly, let's say, because of this sickness. So yeah, the opportunity cost would be that not being treated sooner and having to deal with the consequences of not being treated sooner. Some people also talked about that it can cause, if it is a more serious problem, it can get worse, which is correct. I was not giving too much details here in this example, but yeah, so this is the idea, is what happens, what you lose by being sick all this time. So another concept, and then you'll get rid of me, and this concept is the thinking at the margin concept. You already have the opportunity cost. Now let's talk a little bit about the margin, and then I think Valerio is going to have the tools to explain you economic evaluation and why economic evaluation is important and how it is made. So a lot of the times, I was telling you, for instance, you go to the supermarket and you get either ice cream or chocolate, and that's it. But a lot of the times, the choices between alternatives are not an all or nothing situation. A lot of the times, you need to understand if you should buy, for instance, just a little bit more ice cream, or buy a little bit less ice cream and buy a little bit more of chocolate. These decisions are really made at the margin. And in here, we have this example where you may decide, you have two options in the weekend. You can do some house chores, or you can go for a walk. And you need to allocate your time. You have a certain amount of time and you need to allocate it. And imagine that you are already going to do some house chores and you are already going for a walk, but you may decide that you want to reduce the house chores by one unit, by 1 hour, so one less hour doing house chores, to have that extra hour to do a little bit of a walk outside. And the idea here in thinking at the margin is the following. If I am, let's say, in this example, you would be doing 2 hours of house chores, and we don't say exactly how much you would be doing in terms of outside walk, but let's say that you reduce 1 hour of house chores in order to have 1 hour more for a walk outside. It is very important to understand the marginal change that this causes. So you need to understand what is the change in the benefits. So how much am I going to gain by having this extra hour dedicated to a walk outside? But then you need to understand the cost of what you are giving up. So what do I lose by doing 1 less hour of house chores? And you can say that the cost of giving up that hour of chores is probably that your house is not going to be as clean, and then you cannot enjoy your house as much as you would. And the benefit of going for a walk is that you have some fun, you can relax a little bit. And the answer is basically, if at any point the benefit is higher than the cost of giving up that hour of house chores, then you should go for it. You should take that hour and put it for a walk. And basically, we are talking about hours, but then we can also talk about minutes. In the limit, we could be talking about seconds. So there's this idea that you can marginal is in the sense that you can look at any very small change from one of the activities to the other, and see if that very small change brings you an overall benefit, an increase in your welfare or not. So if it does, you should keep increasing. So that's the idea of thinking at the margin. If I put 1 more minute into walking outside, am I better? Yes, then let's put it. If I put another minute, am I better? Yes, then let's put it. Another minute? Yes, then let's put it. Another minute? No, then let's stop. This idea of thinking at the margin is very important in economics. And it's basically the concept that will lead you to finding the optimal decisions, the optimal way of making choices.
Okay, welcome back, everyone. Now, in the second part, we will cover a bit more economic evaluations in the health field. Luis has kindly explored economics, health economics, very important concepts around health economics and economics more in general. And we will try to see how these concepts can be applied to health economic evaluations. But first of all, let's see what an economic evaluation is in healthcare, of course. It all starts with a choice. Okay, so the first, one of the first slides that Luis was presenting before was about the importance of choice and how economics is about choice. So naturally, in healthcare as well, we're talking about making a choice. In this graph here, you can see we got a choice between two alternatives, alternative A and alternative B. You can think of these alternatives as, for example, a new drug versus an existing drug, a new therapy versus an existing therapy, or more generally, a new treatment versus standard treatment or usual care, basically. Of course, you might have more than two alternatives, 3, 4. Things will get a bit more complex, but we try to simplify things here, so we just present the scenario with two alternatives. We're talking about health economics, so we will of course talk about costs attached to each alternative, cost for alternative A and cost for alternative B. And when we do an economic evaluation, we try to weigh these costs against the consequences attached to each alternative. So the consequences for alternative A and the consequences for alternative B. So what I would like to focus now is really the fact that we are considering costs and consequences together. We are not only considering costs in isolation, we're not only considering consequences in isolation. When we do an economic evaluation, it's about bringing all these different elements together in a comparative way. So we are comparing A with B, so we need to consider any cost for A, any cost for B, but not exactly any cost, any additional costs. Remember that what Luis was covering in the last slide, thinking at the margin. If I'm implementing alternative A, I'm gonna incur certain costs which are on top of alternative B. So if alternative B is what we're already implementing, we really need to consider what cost I might need to incur to implement alternative A. Additional cost, extra cost. In the same way, there might be some costs which are only incurred with alternative B and not necessarily with alternative A, and these type of costs are important to measure and to take into account. That means that if there are some common costs which are common to both alternatives, we don't really need to measure them. We really need to focus on the additional ones, the extra ones, the marginal ones, again, thinking at the margin. And once we've done that, we need to weigh this cost against the consequences associated or attached to each alternative. Now, there are different types of economic evaluations out there. In a way, economic evaluation is an umbrella term which groups or encloses different types of individual types of economic evaluations. In healthcare, these are the most commonly used, the ones you can see here in this list. Cost minimization analysis, cost benefit analysis, cost consequence analysis, cost effectiveness analysis, and cost utility analysis. I will focus in the next slides, I will focus more on the last two, which are probably the most common types of economic evaluations which people use. But as you can probably guess from just looking at the names, even if you never heard of the names before, there is a similar pattern. The cost side is quite similar these types of economic evaluation are based on method in order to capture and evaluate costs which are quite similar. They instead differ in the way they estimate the benefits, okay? And that's, I guess, the subtle way where we can find differences across all these types of economic evaluations. Another key thing to consider is that they're not mutually exclusive. So you will see a research article talking about cost effectiveness analysis together with a cost utility analysis. As you know, there are different ways we can measure benefits, and of course, economists will probably conduct different types of economic evaluation to look at the benefit side, so cost effectiveness, cost utility analysis. And I will talk about a bit more about the differences in the next slide. But for now, I just want again to reiterate how these methods are similar in the way they measure cost, but they differ in the way they estimate the benefits of a particular drug, of a particular program, or a particular intervention. Now, common types of economic evaluation. We got a table here which describes the characteristics of the two most common types of economic evaluation out there. The first one is a cost effectiveness analysis, and the second one is cost utility analysis. Let's have a look at the table step by step. So first of all, let's look at the second column, the measurement evaluation of cost in both alternatives. So cost, as you know, is an important side. We need to measure cost together with benefits. As you expect, both types of economic evaluation in this case try to measure and evaluate cost in monetary units. So, for example, there might be an alternative A which is associated with using a specific drug. You might want to cost this drug, or if there is a therapy, you might want to cost the time that a therapist need to spend in order to deliver a session or multiple sessions of the therapy. So everything has got a cost. My time, your time, the use of a particular drug, the use of particular equipment. And we try to convert that use into monetary units. And that's similar. That's the same across cost effectiveness analysis and cost utility analysis. But now let's have a look at the other side, the consequences, or let's say the benefit side. So how we measure, how we identify consequences. So first of all, cost effectiveness analysis. There is a single effect of interest, common to both alternatives, but achieved to different degrees. Now, I think if we look at the example, which is in the last column, we can understand a bit more what we mean by that. But it's important to note that the single effect of interest is measured in natural units, which is what you can see in the penultimate column. For example, life years gained, disability days saved, points of blood pressure reduction, etc., and etc. Depending on the health area we're looking at, it could be cancer, it could be hypertension, it could be diabetes, there'll be some form of metric which is relevant to that particular health or disease area. Let's have a look at the example, and hopefully things will be clearer. Suppose that you're comparing alternatives A and B in terms of cost and a single effect of interest, or primary outcome measure, which is measured by a reduction in blood pressure. So if you're looking at alternative interventions for hypertensive people, it will be relevant to measure how good they are in terms of reduction in blood pressure. That's probably one of the most relevant forms of outcome you can try to capture. And that's the single effect of interest we are talking about, which is common to both alternatives. So you got alternative A, alternative B, both trying to improve the conditions of people with hypertension. And this effect will be achieved to different degrees. Alternative A might be more effective at reducing blood pressure compared with alternative B, for example. But it's important, again, to note the relevance of the metric we are choosing in that particular, in that specific health area. with cost-utility analysis, instead, we are looking at a single or multiple effects, not necessarily common to both alternatives, but there's still some relevance attached to both alternatives. Typically, these single or multiple effects are measured by healthy years, which are, again, typically measured by QALYs, quality-adjusted life years. And if you haven't never heard of QALYs, I will explain a bit more in the next slide what they are. Well, I presume some of you will have seen QALYs in some papers or research articles. Healthy years, so this concept of healthy years, let's focus on this first. Healthy years accounts for both life years gained and associated quality of life. Or in other words, how well I'm living in a particular health state, and also how long I'm living in that particular health state. So combination of quality and quantity of my health state, basically, the condition I'm living at the moment and in future. So if you think about an intervention which will help me, for example, resolve my hypertension or help me with my diabetes or whatever that problem, whatever my problem might be, I need to consider what health state I am in now, what health state I will be in the future, and how long I will live with my current health state, and how long I will live in my future health state. That's the concept of health years, how long I'm going to live in a particular health state. But let's have a look at the example again. So again, two alternatives, A and B, which we compare in terms of cost, and a single composite outcome. Composite because it's health years, okay, quality and quantity together. We estimate the quality of life changes and the life expectancy of hypertensive patients being treated. Now, you can probably see that talking about healthy years, talking about quality of life, has some relevance to hypertensive people, has some relevance to cancer, people with cancer, has some relevance with for people with, for example, stroke survivors, let's say. So this concept of healthy years is common, is applicable to a lot of different health or disease areas. The concept of health years is typically measured by QALYs, and the QALYs is this common metric which can be applied to different health areas. And if you think about it, it's quite an advantage, because if you're looking at the reduction in blood pressure, yes, it's got a relevance for hypertension, of course. It might have some relevance for other health areas, but it's not widely applicable to every possible health or disease areas with the same relevance. Instead, quality of life is something that, in a way, can be applied, can be measured with relevance to lots of different health or disease areas. So QALYs, or health years, has become really a common metric, which is key in the way decision makers allocate resources across the whole healthcare or social care system, for example. That's one of the advantages of using health years or QALYs, this commonality, this comparability advantage, so the way we can apply QALYs to different health or disease areas. Before I move to the next slide, do you have any questions, or if there are any questions in the chat that we need to address? I'll just move on. Okay. Now, this is perhaps the most technical slide of today's webinar, so bear with me. You see a formula. For some of you, formula are not probably your favorite subject, so but I'm not trying to go into the mathematics of it. I just want to present you what is probably the most common endpoint of outcome of an economic evaluation. And you will see this endpoint a lot in the research articles. This is the incremental cost effectiveness ratio. Again, without looking at the formula too much, you can already see how we are comparing costs and effects together, right? So cost for a treatment, which is T here, cost for C, which is control, for example, effects for treatment, effects for control, they're all brought together. We are not considering cost and effect in isolation. We're trying to express in one number, let's say, these joint effects from cost and benefits. So this is the incremental cost effectiveness ratio, and essentially we try to measure effects by using QALY, or typically we try to measure effects by using QALYs or quality adjusted life years because of the advantages I was talking about in the previous slides. And essentially we end up with a cost per additional QALY. So if you think about, you want to know, if I'm investing some money into the new intervention, I want to know how much does it cost me to get an additional QALY, or how much does it cost me to get an additional unit of benefit? How much does it cost me, for example, to have a point reduction in blood pressure? How much does it cost me to have one avoided hospital admission? Okay. How much does it cost me to have a reduction of, for example, 10 cigarettes smoked per day? Okay. Anything, any type of benefit you can think of. Typically, we measure benefit by using QALY, the quality adjusted life year, but there are other examples out there which people and researchers use. But essentially, this is the concept. Is my investment worthwhile? Or is the investment of the healthcare or social care decision maker worthwhile? Now, I'm talking a lot about QALYs because QALYs is really the common metric which is used to make a resource allocation decision across the healthcare system in the UK. And if you think about finding this cost per additional QALY, it might be something very high, something very small. For example, it might be £10,000 per additional QALY, £30,000. Now, for some people, for some decision makers, £30,000 might be acceptable. For others, it might be too high. Now, if we rely on a personal subjectivity, on a personal opinion around the price of a QALY, then we're not following really a general rule, and we really rely on people's opinions. In the same way that if you, for example, buy a computer, 500 quid might be too high for me, might be acceptable for you, because we all have different opinions about the value of a computer or an item or an intervention in healthcare. So it's important to have a rule we can follow all the time, so most of the time, let's say, in order to decide how much we are willing to pay for an additional QALY, or how much the healthcare system is willing to pay for an additional QALY. There is a maximum to pay threshold, maximum willingness to pay threshold, sorry, which is the maximum cost per additional QALY, which we are accepting to pay. And this is set by NICE, which is the National Institute for Healthcare Excellence. And the threshold is between 20 and 30,000 pounds per QALY in the UK. Okay. There are some exceptions. So this is a kind of general rule, but it doesn't cover all cases. What does it mean? For any intervention which is below 20,000 pounds, usually per QALY, of course, usually these interventions are deemed as cost effective. Any intervention which is between 20 and 30,000 pounds per additional QALY, there is some consideration of cost effectiveness, but there's also other elements that come into play. For example, the innovative nature of the technology, the particular condition we are talking about, the particular type of population the intervention are trying to address, or the intervention is trying to take care of, or the wider societal benefit as well. So there are other elements which come into play together with the cost effectiveness. Anything which is above £30,000, usually, but not always, is considered not cost effective. Now, there are exceptions. For example, NICE has set up in the past a higher threshold for end-of-life care interventions, which has been mainly applied, for example, for cancer drugs. So there are exceptions, but what I would like to focus on is that you will see this threshold being used in research articles talking about economic evaluation set in the UK. So this is the kind of threshold rule that people follow to judge whether an intervention could be cost effective or not, whether it's above or below the 20 to 30,000 pounds per additional QALY. Any questions? I will also say that the quality, as well as other concepts that we covered today, Luis covered in the first part, we have specific vlogs, which are really short, like 10, 15 minutes, around this concept. So if you go to the Arc Northwest Coast YouTube channel, there is a playlist which is about our Simplifying Health Economics series, and you will find loads of vlogs about, for example, opportunity cost, qualis. There is a link which you will have at the end of these slides. You can access the playlist and you can have a look at all different concepts. And if you want, of course, to explore more qualis, we have a dedicated blog about qualis as well. Okay, Luis Mizel, is there any questions or can I move on? Okay, that's great, thank you. Now, this is a typical, I guess, slide that any session on introduction to health economics will cover. Usually, I think this is displayed at the beginning, and it's just a collection of different headlines, which you've probably seen in the paper before. Maybe not exactly these, but similar ones. Headlines which talk about, drugs being refused, potentially life-saving drugs, and there's probably a sense of injustice, unfairness, which might emerge when you read these headlines. Now, typically, as I say, this is a slide which is displayed at the beginning, and then as you go through an introduction to health economics course, you understand why health economics is relevant. Of course, these types of decisions are not made on a whim. There is some thinking, there is some reasoning, which takes into account health economic considerations. So hopefully now you will have understood why health economics is important and why it's important as a tool to make an effective use of the resources available, but also an efficient use of the resources available, make the best use of any resources you got available in the healthcare, but also, of course, you talk about economics in general in your life, in your daily life. Now, talking about efficient use, but here we see headlines which really trigger a sense of unfairness. As I said before, it's important to know there is a relatively new strand in health economics which takes into account equity, which takes into account fairness. So the decision to allocate resources in healthcare to, for example, cancer, will potentially remove resources or displace resources from other areas, which might have an impact on, for example, people coming from deprived areas. So there is a socioeconomic element we need to consider, and it's important to note a new strand of health economics is looking into this. It's looking at how healthcare or social care decisions around the use of resources is looking or is impacting on the equity, on health inequalities in terms of access to healthcare, in terms of potential loss of health gains from making decisions which displace healthcare or social care resources. And that is very important. So it's not only about how to best spend our resources, but also to make a fair decision. And you probably can guess that is a very tricky scenario. It's a very tricky thing to do, try to balance fairness, equity on one side, and efficiency on the other side. Okay, I can see some notification in the chat. Is there any questions we need to cover?
We had a question. I was answered, but you can also give your
Okay.
answer. It's by Terry Bryant. As health knowledge develops and changes, for example, the growing recognition that inflammation, for instance, of the blood vessels, organs, etc., is a major causal factor of many conditions. Doesn't this make these economic computations continuously in need of refinement?
Yeah, okay, no, absolutely. And there is I don't know what you answer, Luis. So you want to say your answer first, and then I'll probably complement.
To be
Got my
sure that you
ideas,
don't
yeah.
say anything different.
Yeah.
No, what I was saying was that yeah, you have information about a certain condition, and you believe that the benefits of treating a certain condition are some benefits. If you get new information saying that apparently that condition was more harmful to your health, and treating it brings then bigger benefits, then you need to update those benefits in any type of economic evaluation, sure, and that is potentially going to make a difference because you had some benefits for some costs, and now you just realize, okay, the benefits are higher than the ones I was predicting. So the relationship between benefits and costs is going to change in favor of better cost effectiveness. That would be my answer.
No, I think I agree, and it's really evolving. And of course, when you do an economic evaluation, it takes, if you're lucky, months, but it will take years probably. And by the time you produce the results, it might be outdated, yeah, because innovations come very frequently, and unfortunately, that's a price we have to pay as an analyst. But in a way, there's always work to do, I guess. So there's always like a demand of our work, and this is this is something we need to keep abreast of, like innovation and making sure that we are analyzing data which reflects the most advanced technology, most advanced treatment in that particular area. Yeah. Okay, I can't see any other answer, but please let me know if you have any questions. Otherwise, I'll move on. Sorry, I can't see any other questions. Okay. Okay. Now I'm going to introduce this new initiative from the MIDAS theme, which is called the RACEs, Rapid Conversion of Economic Evaluations. Now, as the name suggests, it's going to be part of the RACEs program. You probably heard of the RACEs program before. RACEs stand for Rapid Conversion of Evidence Summaries. I would say it's probably one of the most successful programs for our MIDAS team, also across the ARC West Coast. In terms of what we intend to do is to have people from the ARC West Coast. So this is a real initiative open to anyone from ARC West Coast member institutions. And we are going to take together an existing economic evaluation. So an existing paper talking about an economic evaluation, and we are critically appraising this economic evaluation together, and then build on the findings from the economic evaluation in order to draw some implications for policy, practice, and future research. Again, if you know about the RACEs, you will see the similarities here. Of course, RACEs focus on systematic reviews. We are going to focus on economic evaluations, but similar type of process. What are RACEs for? Are anyone from ARC West Coast member institutions. And our objective is to make sure that you grow your skills in health economics, so you will have access to our little but valuable, let's say, health economics team in MIDAS, and you will grow your skills in critical appraisal. So it's a co-production, it's a collaboration between us, the academics in a way, and you in terms of developing grow skills in health economics and critical appraisal. And finally, you can publish a paper. So as you probably know, there is a relatively quick turnaround for RACEs, for example. People tend to draft RACEs quite quickly, and the journals have a quick turnaround in terms of reviewing them and setting them. Hopefully it would be the same for the RACEs. And you can aim to publish a paper in a relatively quick time. What's the price? It's free. So in terms of opportunity cost, really little decisions here, isn't it? So it's free for anyone in the ARC West Coast. If you want to see an example, now you got a QR code here of an existing, already published rapid conversion of economic evaluation, which Luis and I did last year with some clinicians from Royal Preston Hospital. you got access to the slide later on, so you can have access to this article, and you can see how we work with these clinicians in terms of critically appraising an economic evaluation and making sure we add this implication for practice and avenues for future research laid out in the commentary we wrote together. Now, I'm going to talk a bit about the content, and then I'm going to also talk a bit more about the logistics in the next few slides. But about the content, we would like to give you all the skills you need to take an economic evaluation, read it, interpret it, and critically appraise it. So it might take some time, it might take some time and resources to grow your skills around all these elements. But we are going to try to cover everything you need to do. Now, we are not expecting you to become a fully fledged health economist. There are things we ourselves need to learn every time. So this is just to give you the skills in order to write RAC together with those, of course. So in our session, there are 6 sections, and I'm going to just cover very quickly what we're going to cover in each session. These are online sessions, which are going to start from May until July, and then we will have a final workshop in September. In the first session, we will help you identify an economic evaluation, so an article around your topic of interest. You can choose the article, and we can then start working on this article together. Session 2 is about finding the key attributes of an economic evaluation, which really should be present in each article. And again, we'll go through with you about what to look out for in terms of finding these key elements of an economic evaluation. Session 3 is about costs. Again, how to read, how to interpret the costs information within a research article. The same for the outcomes, which we will cover in session 4. And then we will look at the analysis, so the results section, and try to interpret the analysis, sensitivity analysis. Session 6 is kind of optional. It's a Q&A session. Any questions that might arise, we can discuss them together. And then the final bit is the workshop, which will take place in September as part of the wider ArcFest in Kendall. But what is important to note is that hopefully you will work with other people, so in a team. So you will have a topic of interest which will be common to other people. We will put you in the same team. You don't need to attend each session. The session will be available on demand as a recording. You can even task share with other people in the team. Like, for example, you can decide to attend session 1, another person can attend session 2. At the end of each session, we will give you some homework to do, and that homework really literally consists of writing up the RAC. So when you go to the workshop, you got most of the RAC completed or drafted. And then at the workshop, we will do the critical appraisal together, and we will talk about implication for policy, practice, and future research. In terms of dates, as I mentioned, 6 online sessions of 1 hour each. Again, they're available on demand. You don't need to attend the live session, but they are going to be available on demand, and 1 face-to-face workshop in September. These are the dates that we set up. So as I was mentioned before, the course will start from May, exactly from the week starting on the 13th of May, and you have 2 sessions every month, basically, finishing in July, and then the workshop, which will take place in Kendall on Tuesday, the 10th of September, as I said, as part of the wider ArcFest. Now, how to sign up? So hopefully you will have grown some interest in health economics after this session. You want to engage in our RACES course. So we have some places available. There's only 4 of us. So we would like to allocate each one of us to one particular group or individual, preferably group, so you can work with other people. So I will be allocated to one group, Luis will be allocated to one group, Misael to another group, and Andy to another group. So there are maximum 4 places available, and it comes on a first come, first served basis. So I will share the link in a minute, but it's important to note, if you're not able to take part in this run of the RACES, there's going to be another run in future, and we can put your name in a waiting list for the next run, which will probably or presumably will be in autumn or winter. And this is the link to the form to register. So again, you'll have access to this in the slides. We will share with you in an email. It's a simple Microsoft form where you can express your topic of interest if you have any. So if you have, I think it's maximum 3 topics you can express. Also, you can express your preferred date and time for each session. So we will try to accommodate as many people as possible in terms of date and time for the sessions we are going to run. That's why I was talking about week starting before rather than actual dates, because we are trying to really accommodate as many people as possible in terms of availability. But as I said, recordings will be available on demand. You will have a personalized team space, Microsoft team space, where you can work with the other members of the team. So you can interact with those as well, and everything will be organized for your particular group and your particular team. Okay. Any questions you have about the races or any information you might want to know about the races? Okay, thanks, Luis, for sharing the link for the registration form.
So in the meanwhile, sorry, we have a question from Terry Bryant. So do not the accountants or government have a much louder voice than any medical clinicians in decisions of health economics in this country?
Oh, I don't know, to be honest. Don't know. Don't know if anybody can answer that.
Topic.
Yeah. Oh, yeah. It's a difficult question, this one, yeah.
Well, they definitely have the last word, right?
Yeah.
At the end of the day,
yeah.
the decision makers are the ones that decide whether or not something is implemented.
Absolutely, yeah. But it's also, in a way, like I think we covered that in one of our blogs before, like how societal preferences play a role, isn't it, Luis? I think you covered that in one of your blogs about
Yes.
yeah.
I have shared in the slide the link to our webpage, our MIDAS webpage, where you can find a series of blogs about economic evaluation. One of them, like Valery is saying, is about how decisions are made, the importance of having some subjectivity versus its costs.
Yeah.
So yeah, just a very simple and quick blog on that.
And there are things which acquire momentum in particular moments or years. There are certain disease or conditions that acquire momentum, like cancer or dementia, for example, and that's something the government needs to take into account. And there is preferences from the government or the Ministry of Health, that will take relevance. Yes, absolutely. So as the economist, I would say, yeah, they play a role for sure, but the relevance of the role is of course fluctuating. It's not always going to be the same.
Yeah, but let me just say that sometimes the role of the economists or the role of some decision makers is to be the kind of the what can I say? It's a little bit hard because they will check the effectiveness. Let's say we have a new drug, they will check the effectiveness of it, and it can save a life, and they may decide just not to put it into the market because it is too expensive. So the idea is that they believe that by buying that new drug, let's say, and by saving that life, they are probably giving up some other lives because of the money they are not putting elsewhere. So it's really tricky. But yeah, I would say that clinicians always have a saying in terms of understanding the efficacy of the drugs, and understanding that some drugs, some therapies, some treatments, etc., may be the best for their patients. But then what the decision makers do is the other part, where they say, okay, even though we understand that it may be the best for your patients, we are not sure that if we put this much amount of resources in that we are not harming the other patients more. So it's really tricky, and it basically brings us to ethical and other types of questions, which I very, very briefly talk about in that blog in particular. So you may want to check it, but yeah, it's never like an easy thing to do, and never an easy answer. You need to take more into account. It's not only economic evaluation; it's also ethical issues and societal preferences and so on, like Valerio was saying.
Absolutely, yeah. Oh, thanks, Luis. Okay, if there aren't any questions about the races, I'll move on, and then just to give you a very, really quick description of further info which you can find online. We talked about our series, Simplifying Health Economics series. You got the link here to our vlogs, which you can find on the ARC Norwest Coast YouTube channel. This is a really, I will say, really useful glossary of health economic terms, which you can find here, provided by the York Health Economics Consortium. I regularly refer to this glossary, and is a really good source for understanding or refreshing your memory around some terms. And also you got another series of links and websites and resources available online, including a very good Kenneth Arrow's interview. Kenneth Arrow was mentioned by Luis in the first part, and it's a very inspiring interview which you can watch online. Now, before we finish, so we are now at the end of today's webinar, we got an evaluation survey. So regarding this webinar, we will be really grateful to receive your feedback regarding this webinar by completing our quick 3-minute survey. I can guarantee it's really 3 minutes, no more than that. And you got, again, the link here. We can share the slides later, so you'll have access to this survey. And we will be really grateful to hear your views on this webinar. Hopefully you liked, but if there's anything you think we need to improve, just feel free to let us know, of course. And I think that's all I need to say. So I would like to thank Luis for co-running this webinar with me. Thank also Misael and Andy for being here today and monitoring the questions in the chat. If I'll stop share the presentation, yes. If you have any other questions about the races or anything we covered today, I think Luis and I are happy to stay for another 5 or maybe 10 minutes, whatever. But otherwise, we really wanted to thank you for coming today, and I hope we hope you really like the session and you like health economics a bit more, I guess. And we'll see you more. We'll see you later on, hopefully at the races or in the ARC Norwest Coast. Thank you, everyone.
Thank you.